Kirsty Prasad will present the third of 3 consecutive series about working effectively with women who use substances. Today's session is titled Trauma and Addictions. Before I introduce Kirsty, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right-hand side of your screen. A session facilitator is monitoring the questions and will pose them at suitable times during the presentation. If we aren't able to answer all the questions during the live presentation, we will answer them via email after the session is over. It's important that you do include your email address when you ask a question, otherwise we will have no way to send you an answer. The presenter's contact information is on the back of your handouts and on the final slide of the presentation. In order to receive your certificate of attendance, you must have signed in after 8:50 a.m. Evaluations for the session will be emailed to you after the session. Please do fill them out and return them, as we do rely on your feedback to continually improve what we do and how we do it. Today's presentation handouts will be posted for viewing and downloading on the CMC website, which is fasd.alberta.ca. If you do experience any technical difficulties, please contact Clayton by email at Clayton, CLAYTON.Knoll, KNOLL, at teacher.stv.ca. Also, please let your local tech support know, as the problem may end up originating at your end. As Alberta advances with the FASD 10-year strategic plan, education and training continue to play a key role. This is our 5th year of offering sessions and our 2nd year of delivering training, the material as webinars. As always, all sessions are taped and made available on the CMC website, which is fasd.alberta.ca. We are pleased with the ongoing interest and attendance in this initiative. We appreciate the work of CASA Child, Adolescent and Family Mental Health and the Alberta Centre for Child, Family and Community Research in making this initiative a success. Now, I have the pleasure of introducing Kirsty Prasad. Kirsty has worked with AHS Enhanced Services for Women since 2002, where she works with women who use substances. In recent years, Kirsty has been training other service providers in strategies and techniques that she and her AHS colleagues have developed. Prior to coming to AHS, Kirsty worked for Streetworks and Mental Health Unit in the inner city. She has a strong knowledge and passion for working with marginalized populations with substance use concerns. We're fortunate that she's going to share her wisdom and experience with us for the next 3 learning sessions. Please join me in welcoming Kirsty.
All right. So good morning, everybody. I know that we're just running a little bit behind due to some technical difficulties, so we apologize for that. But hopefully we'll be able to get through all the material in a timely fashion. What I'm going to do, though, just because we had some questions from the presentation we did last time in November on gender issues related to women who use substances, and so I want to make sure I addressed a couple of questions that we weren't able to get to last time, and then we'll get into some of the information around trauma-informed practice when you work with women who also use substances. So the first question that we had was, are there any legal repercussions to agencies who refuse to service or accountability for workers, such as the one who told the woman that she would kill her baby because she used while she was pregnant? And so the scenarios that I talked about last time was a lady went in to get some support after being severely sexually assaulted, and she was refused service based on that. Based on the fact that she didn't want to report to the police, and there was some stigma related to her because she worked in prostitution. And the other one was a young lady who was concerned about relapsing in her 3rd trimester, and the worker said that she would end up killing her baby if she used, which was false information that she gave her. And so what ended up happening, ethics did get involved for the first scenario. The second one was a little bit more complicated. Information went back into the agency that happened. The outcomes, we don't always know what the outcomes are in regards to that, but there was follow-up in both cases in regards to the information that the community knew what happened. So And the second question is, despite a service provider's best intentions to be non-judgmental, I continue to encounter many situations where there is a tendency to blame the mother, birth or other, particularly by female service providers, and overlook the many factors involved in her life. What would you recommend to service providers to minimize or reframe these ongoing belief systems? And that's actually a really good question. When we first talked about values and attitudes in session 1, and I think it's really important when we understand the complexity of substance use and how really it's, sometimes I think people believe, you know, you pull yourself up by the bootstraps, just say no, and then you'll be fine. And it's a matter of willpower, or sometimes people believe pregnancy is a cure for addiction. And there is a lot of stigma that's related to women who are using, and if they are pregnant. The difficulty is it's not so simple, and there's so many complexities and reasons why women use. And I always say substance use is always a symptom of something else that's going on in their life, and usually it's a critical incident that's been going on for them. So it's, again, trauma, death, bereavement, domestic violence. It's always a symptom of something else that's going on in their life. And so always making sure that we reflect and we understand why someone might be using. The other piece to this, and I think it goes back to your place of employment. I know for us, we are very lucky that we're able to do a lot of clinical supervision, and we have the support to be able to, in a safe place, talk about and do a lot of self-reflection in regards to why we make decisions, or why we felt a certain way, or why we did something in a session, and be able to really kind of peel that onion away and understand what was our purpose, and if there's things that are kind of being transference, I guess is the best way, if there's some transference going on, and understanding why we're going in a certain direction. And the other thing in regards to that, I really believe one of the philosophies we always use is to mother the baby, because we always have that challenge, who's our client or who's our patient, and we get torn between the baby and the birth mom. And so I always say, you know, to mother the baby, you need to mother the mother. And to really support that child, you really need to support the mother and understand where she's coming from. And that's the best way. And always reminding yourself of that, that's the best way to support both of them, is to truly support the mom. And that's the way you can maybe help challenge some of those belief systems. Because to be honest, I've never met a woman who doesn't care. In all the years, and I've met lots and lots of women that have used during their pregnancy, and I have not met one woman who does not care about that child. And sometimes they come in with this really tough exterior, and they may present a certain way, but it's always a facade. And I always say the ones that come in, you know, with this really tough exterior are probably the ones that are hurting the most on the inside. And so, like I said, I've never met a woman who doesn't care. So hopefully that answers those two questions. And we'll get into some of the information in regards to trauma and substance use. So we'll go through some myths and facts again. So trauma experiences are the same for men and women. Would you say that's true or false? We have a few people in our room, so I can get some feedback from them.
I think it's false.
So yeah, absolutely. And I'll go into some of the research around their experiences as well. And every myth and fact that I do talk about, I will talk about a little bit later in much more detail, but that one is false. Women are more at risk for interpersonal abuse. Would you say that's true or false?
True.
Absolutely true. And I'll give you an example of the development and the different stages of life for boys, teenage boys and adult boys versus women. The reasons for no disclosure of trauma are different for men and women. Would you say that's true or false?
True.
Absolutely true. Women are more likely to report childhood sexual, physical, emotional abuse, and adult sexual assault as a critical incident.
True.
Absolutely true. Men are more likely to report combat, accidents, and exposures to crime. true. And I have some stats on that as well to show you to compare that. Men report experiencing more traumatic events than women. This one might be a bit of a, This one's actually true. And I'll show you some of the stats of why that is. People who have experienced trauma have a high rate of substance abuse. Absolutely true. People must wait to have abstinence from drugs and alcohol before they can work on their trauma symptoms. Absolutely false. And I know throughout the first two sessions I've kind of touched on this quite a bit, but I just kind of want to reiterate. I think sometimes people look at working on trauma means doing some of the age regression and the in-depth intensive trauma therapy, but looking at the work that we can do and the support we could provide is a continuum. And just to support someone who has extensive trauma history, you can work on the symptoms without having to go into detail about what's occurred for them. And to really look at when we work with people who use substances, if we're going to ask them to get clean and sober, but we haven't taught them how to emotionally regulate, how to cope with the different symptoms around their trauma, we could actually be doing them more harm because we haven't replaced ways to cope in a healthy way. You must specialize in trauma to support a person who is experiencing trauma symptoms. That one is false. And I think sometimes, and I've noticed this in the field, I think we're getting a lot better because we're much more trauma informed and there's a lot more understanding and interest in the topic. But I do believe some people fear working with someone that might have trauma because they feel like it's not their specialty and they have to refer them to someone that has a specialty in it. And when I go through the trauma-informed principles, and there's 10 of them that I'll go through, it'll show everybody from a dentist's office all the way up to a therapist who specializes in trauma can support somebody who has trauma symptoms and has a history of trauma. Trauma symptoms may at times look like withdrawal symptoms or using behavior. Would you say that's true or false? Absolutely true. I think sometimes people might misinterpret some of the symptoms that are being exhibited and think that someone might be using or in active withdrawal. And sometimes it does look quite similar and we might misunderstand those cues and miss an opportunity, or we may end up causing a little bit more harm because we aren't aware that's what's actually going on for them. So trauma recovery has a high relapse rate, and that's in regards to substance use. Absolutely true. Yeah. Women are more likely than men to develop PTSD after a traumatic event. So I had the slide that said that men are exposed to more traumatic events than women, but this one's asking, are women more likely to develop PTSD? It's true. Yeah. So here's a couple of definitions in regards to trauma. I thought that I'd just kind of throw them up there. I mean, the DSM-5 has their definition, and there's a lot of different places that have a definition on that. But I thought we'll throw in a couple ones from the American Psychological Association. And it says the person's response to the event must involve intense fear, helplessness, or horror. Or in children, the response must involve disorganized or agitated behavior. Trauma, or through Bessel van der Kolk, quite well known in regards to his work in trauma in the United States. He's defined it as trauma occurs when an external threat overwhelms a person's internal and external positive coping resources. And so basically what they're both saying is it's not necessarily the event, it's the perception and how we cope with the event after the fact that can impact a person whether they may start experiencing symptoms around PTSD. So I'm just going to use about 3 different studies to compare in regards to substance use, women, and trauma. So the first one was done through SAMHSA, and there was 14 sites. And to be a part of this study, you had to have services that provided trauma, mental health, and substance use. So here's some stats in regards to PTSD in Canada. And in here, the things that kind of stand out, I just wanted to point out. So when we talked about men's exposure to trauma is higher than women. So we have seeing someone badly injured or killed, 41% for men, and it's 23.5 for women. Vehicle accident, 22.9 for men, 13.1 for women. But what you'll see what's different for women is they have reported a higher incidence of sexual assault or sexual molestation. And so when we look at trauma events, I think it's important that we recognize all the different trauma events, and that's where for men their exposure to trauma is a little bit higher. So 75.9% reported lifetime exposure to one or more events. And then when you look at that, when we look at the two means in regards to men and women and their exposure, women are a much higher rate in regards to being diagnosed with PTSD, so 12.8% versus men, which is 5.3%. And so we're twice as likely to have the diagnosis of PTSD than men. And we just wanted to compare it a little bit to stats in America and Sweden. So in Canada, our exposures to traumatic events is 75.9%, like I said. U.S. in the city of Detroit, their stat is 89.6, which is quite high, versus Sweden, which is 28%. And I didn't put it up here, but there's a stat for China, it's 0.01%, which is quite low. And so there's probably a lot of different reasons why they're showing pretty much next to no exposure to traumatic events. But just wanted to compare it throughout the world. In regards to this study, and it talks about substance use in women, and they did a study in regards to different treatment sites across Canada. And so this is what I want to relate it to. Health Canada has a stat of 85% of women that enter addiction treatment services have a history of physical, sexual, emotional abuse. This study shows that 73% of women accessing treatment report childhood abuse, 62% of them report abuse in their adult years, and 90% of them report any type of abuse trauma. So that stat's a little bit higher than the Health Canada stat. And then we have, before I get into this one, so I just want to comment on, so when we're working with women who use substances, I think it's probably best to maybe assume that they may have a history of trauma and then weed out the ones that might not, because the stats are so high. And it is, like I said, that study shows about 90%. For the work that I do, it's actually 100% of the women I see have a history of physical, emotional, and sexual abuse multiple times throughout their life. And so I think just, going in with the lens of a trauma-informed lens is really important when you work with women who have substance use concerns, because a good chunk of them probably have a history of trauma. In our last session, we talked a little bit about the Adverse Childhood Experiences study, which was pretty groundbreaking in regards to understanding people's experiences of trauma. And so it was done through the HMO in the United States, and there were 17,000 people that they asked 10 questions to, and their experiences of trauma before they turned 18. So I kind of put up here some of what the 10 questions were. And so you guys can just have a look at that, but really questioning whether they've been exposed to physical, emotional, sexual abuse, neglect, if their parent used alcohol or drugs, if a family member was in prison, if they had a family member that was mentally ill or chronically depressed, or they witnessed domestic violence in the home, or they had both biological parents not present. And so some of the results that came from that is for people reporting 5 or more adverse events, so answered yes to 5 or more of those questions, their likelihood of misusing substances increased 7 to 10-fold. Women were 50% more likely to have a score of 5 or more. And I mentioned this before, if a male scores 6 or more, his risk of becoming an injection drug user increased by 4,600% compared to a boy that had 0. Huge. Severity of childhood emotional abuse correlated with increased substance abuse in both sexes, and more evidence for an association of ACE and alcohol and drug dependence in women than men. So it's saying women are more likely to have dependency on substances, but for men and women, if they've had early childhood experiences, their chances of having a substance use disorder or concern is quite high. And so this study was quite important in really making that correlation and that link in regards to substance use and trauma. And so this is a quote from, and it's anonymous, we don't know who wrote it, but it says, "I have come to believe that trauma is the problem and substance use is the solution until the solution becomes the problem." And so like I mentioned earlier, again, it's always a symptom of something else going on, and it's a way they've used to help cope with the different experiences that they've had in their life. And then what ends up happening is because it starts to have a life of its own, and then it becomes the problem in their life just as much as what was going on for them. And in a few more slides, I'll talk about the importance of understanding why people use as well, because for a lot of the women I see, you'll see a correlation between the different trauma symptoms and why they might be using certain substances, and the importance of understanding the positive benefits that they get out of using those substances. So when I'm working with someone that has a history of trauma and they're also using substances, sometimes I wonder, as a counselor, I say to myself, okay, what is it that I really need to work on? What are the areas that I want to make sure I address when I'm working with them? And so here's 4 key impacts that kind of is like a theme throughout the work that I do with the women I work with. So we know that trauma really impacts a person's identity. And I think it's really important to understand the impact on their identity, who they see as themselves, how they view themselves in relation to the world, and having the ability to understand that is greatly, greatly impacted for them. Boundaries. And I know, like in a lot of addiction treatment, in the addiction treatment world and a lot of therapy world, we talk about boundaries and how boundaries are greatly impacted by their substance use. By their history of trauma, sorry. But I think it's really important to be quite aware of the depth of how boundaries are greatly impacted for them. I touched on it quite a bit in the first 2 sessions, and I know I harp on it a lot, but I think it's really, really important to understand how trauma really impacts their affect regulation, their ability to regulate emotions. And so what they end up doing is looking for external ways to self-soothe, to regulate their emotions. And what we need to do is help them learn how to internally self-soothe and regulate, because they've always looked at external ways. And that goes back to the boundaries. That's where the relationships come from, that they're finding external ways to help them self-soothe and rely on different things to help them do that, where it's, like I said, the relationships, the substances, eating disorders, the self-harm, all those different areas that they're finding ways to help. And lastly, attachment. This area, and I'll talk about trauma reenactment, but I think it's really important to understand that sometimes what people with trauma histories do is they reenact the traumas, and when they have attachment's greatly impacted by, because a lot of times getting close to someone is quite difficult, or they can't regulate their emotions, and what they end up doing a lot of times, like I said, they try and reenact the traumas that they've had, and they'll do that within relationships. And us as workers really need to be cognizant of that as well, because sometimes we will, I'll touch on it right now actually, sometimes we will actually become a little bit more rigid, and we will refuse services because, one, for example, one of the things people will do is they'll miss appointments. They'll connect with you and then they disappear for a bit. And that's not uncommon. It's like the push-pull thing where they want to get close and then they push everyone away, and then they get close and they push everyone away. And sometimes they need to test the waters, and so attachment's really greatly impacted for them. And so for us as service providers, it's really important to understand that. And when I talk about therapeutic alliance later on, which is really important when we're working with someone can appear to be really engaged with you because they've shared a lot, but doesn't mean they actually have that therapeutic alliance with you. And so being really cognizant of that piece is important when we're working with them. So in some of the myths and facts, I talked about the different areas, a little bit around people's exposure to trauma and their trauma symptoms. We've touched on it a little bit, but I want to make sure that we kind of break it down a bit. And so what the effects of trauma might look like physically when they come in, emotionally, cognitively, and spiritually. And so physically, you'll see eating disturbances, sleep disturbance, pain in the areas of the body that had been involved in the traumatic experience. And so, for example, you'll see some of our clients will say, you know what, I'm convinced I have a bladder infection. I'm convinced I might have uterine cancer. And they go into emerge and they keep going in and they get tests done over and over and over, and it comes out that they don't have any infections, they don't have cancer, but they're absolutely convinced, and they keep going back. And so sometimes, you know, when we look at some of their trauma history, because I think it's important to understand that I use the analogy, what the mind doesn't remember, the body does. And so sometimes it comes out in a lot of different ways, and so that's where they will feel a lot of the pain and chronic pain and are absolutely convinced there's something going on, and so that's part of that. I put this one under the physical experiences because I want to touch on it a little bit more, because we've talked about, I think we're quite well versed in the fight, flight, and freeze. We talk about that quite a bit, but for us, we also add in a little bit more around the F words. That's what we call them. And so we also added in fidget, faint, feed, and fool around, because I think we need to understand that it also presents in a lot of different ways, and it's not just those three. Going back to those three, I'm going to touch on the freeze part really quick. I think this is an area that maybe we don't always have a conversation with the women that we work with in depth, and I think it's really important that we touch on this piece, the education, because there's a lot of guilt related to when we freeze. And knowing that it's an actual biological response. It's like that term deer in headlights. You know, if we know we can't run, we know we can't fight, we freeze. It's an actual biological response, and sometimes the women we work with have a lot of guilt around that because they don't understand that that was a way they did to protect themselves. And so, yeah, let's move on. The other one is flashbacks. We talk about flashbacks quite a bit, and I think we have a lot of understanding around that. The only thing I really want to touch on is sometimes we talk about flashbacks being memories. And sometimes when we talk about them being memories, it almost waters down the experience of a person who experiences flashbacks. And so it's really important to recognize when a person experiences a flashback, it is like they are reliving that moment again in the moment that they're having it. And so it's important to understand why someone might be using substances, because they can't cope with the flashbacks, because again, it brings them right back to that moment, and every ounce of every part of their being is reliving that experience. And knowing that sometimes the flashbacks aren't visual, it's not like the movie playing, and so they'll have flashbacks where it's auditory, they might have scent, they might have a body flashback, and they might not realize that they're having flashbacks, and they might relate it to having a panic attack. Or they will smell something, and then they have such a response to it, and they don't understand why that smell destabilizes them that quick. Emotionally. So you'll see it present as depression, anxiety, again the panic attacks, really intense fear. You'll see a lot of compulsive and obsessive behaviors, feeling out of control, the emotional numbness, frightening thoughts, difficulties in relationships, and anger. Behaviorally, what you might see is, again, the self-harm, the substance use, a lot of the self-destructive behaviors. When I do this presentation, and I try and do it pretty interactively, so doing the webinar, it's a little bit harder to do this as interactively and do some of the activities that I make it much more rich, actually, so I'm not the one always talking, but I do ask the question in regards to the self-destructive behaviors, in regards to, the things I've already said are very self-destructive, but what other ways do we see clients doing self-destructive behaviors? And sometimes we might not relate it to that, and so we've talked about where, some of the high-speed chases, or doing armed robberies, or even sabotaging, a lot of the self-sabotage, and so different ways that it might present versus just the substance use and the self-harm that we can relate back to the trauma. Suicide attempts, over-engaging in relationships, and again, like I said earlier about missing the appointments, I think it's really important to recognize that part. And so a lot of the clients we see, I always say the work we do with them when they have a history of trauma is much more slower, much more in depth, and it takes much more time. And so this is a piece that is quite common for the women that we see, is around missing these appointments. So cognitively, so memory lapses, loss of time. I'm going to touch on that really quick because I actually usually do a case scenario when I do this presentation, and what we have is a lady presenting for support, and she wants to go to treatment, and she tried to access detox, and it's been 7 days that she had used, and so detox is like, we can't have you come in, because you're not actually in active withdrawal, and so sent her somewhere else to get the support she needed, and she kept talking about how she needed to be safe. And she did present like she was still in active withdrawal when she came in. And so when the person, and in the scenario, and we talk, I won't go too much in depth of it, but in the scenario, part of what happens is when they start asking about her history of use, she is getting agitated because of some of the other questions that were being asked, but she kept going, I can't remember, I can't remember, I can't remember. And so sometimes what people will call that is they're being evasive. They're not being truthful. And how can you not know how much you use? And sometimes we'll look at it in a very negative way. But the purpose of the scenario is, one, sometimes our assessment tools can make things worse. And if we focus so much on our assessment tools, we might miss the opportunity to be very client-centered and supporting the client. That was the purpose of the scenario. But also to recognize that because she was experiencing a lot of trauma symptoms at the time, and then asking her about when she first started using and getting some of her history, and she was like, I can't remember. For this scenario, that person at that time, when she first started using is when she was being molested as a child. So she experienced a recent trauma. In the scenario, what ended up happening is she was sexually assaulted, and she became pregnant from that assault, and once her partner found out, he actually beat her up, threw her down the stairs, and she miscarried. And it's based on a true scenario. And so when she came in, she wanted to be safe and she wanted support. She was feeling very symptomatic at the time around what was going on for her. But when we start asking questions about her history, then we're also, without realizing it, regurgitating when she first started being molested. And that's where some of those memory lapses happen, because, when we're in shock and we're experiencing trauma, our memory is stored differently. And sometimes, we need to look at how do we support that client. And I think also one of the things we miss a lot of times is the disassociation. I think we recognize a lot of the other symptoms. I think sometimes we have a harder time recognizing when people are disassociating. And it's very, very common for them to disassociate, and that's where they get those chunks of time that's being lost. Spiritually, feelings of guilt, shame, self-blame, and self-hatred. What I'll comment on that one in regards to the self-hatred, I know sometimes we'll talk about, clients need to be sent to a self-esteem course and we need to work on strength-based practice. And absolutely that's very true. But I really want to get to the core of that experience for them, of that self-hatred. It is in the pit of their stomach and it's so deep. I mean, I have women that say every second of every day, I hate being in my own skin. I hate every part of who I am. Like, that self-hatred is to the core. It's deeper than just saying we need to help them with a self-esteem course. I have women that cover their mirrors and haven't looked at themselves in years in their home. Like, they'll cover the mirrors in their home because they can't even look at themselves in the mirror. That's how deep that self-hatred is. And so really understanding what that's like for them. And that's why I say the work is so much slower and so much more in depth and takes so much longer, because of that is such a strong piece for them. So trauma and substance use. In regards to, what I'll do is I'll give you an example. When we talked about women being at most risk for interpersonal abuse, when we have, I'll give an example, and I've heard this from Stephanie Covington, and it's always sat with me, and it's always hit home around really describing the interpersonal abuse that women experience versus men. And so if you have a young boy and a young girl, who would they most risk having harm done to them by? Usually it's a family member. When you have a teen boy and a teen girl, who are they most having risk done to them by? For the teen boy, at that time it starts to become acquaintances, people in the social circle, but someone they don't necessarily know, but in that social circle. For a teen girl, it's a family member and a partner now. When you have an adult female and an adult male, who are they most risk having harm done to them by? For the adult male, it's combat. For the female, it's a partner. So throughout our life, the person that, for women, that we fear the most and are at risk of having harm done to us by is someone that is closest to us. There's also a gentleman in the States, he's a security specialist, and he wrote a book, and one of the things that stood out for me in that book, he asked men and women, in a relationship, what do you fear the most? And so the men said that the thing they feared the most is rejection, and the thing that women feared the most is being murdered. So interesting, right? When you look at what we fear in relationships the most, how completely different that is. And I think there's a question.
Yes, I've got a question here from Gary. When children have experienced trauma in early life, how do we help, but in the same time, not take them back to the traumatic event?
Oh, that's a good question, Gary. That's a very good question. I think actually Jean might be the one to answer that one even better than I am. The only reason why is I specifically work mostly with adults. I mean, actually, my age range of working with people, for women, is childbearing years, which is 12 to 53. It's quite a large age range. But I do usually work with the parents versus the young children. But I think Jean could answer that one probably better than I could.
Yeah, Kirsty, I think actually Gary is asking about an adult who's experienced childhood trauma. And so and I would have, add to that question, how do you actually gather important historical information without re-traumatizing? And I think that's related to what Gary's asking as well.
Thank you. Very good question, actually. Near the end of the presentation, I will actually go into some strategies that you could work on that help with skills and coping, so you don't actually have to get the specific information from them around their childhood abuse or some of their trauma experiences. And I think one of the things I actually really suggest is people reevaluating their assessments. What ends up happening, and I've looked at a lot of different assessment tools, and what ends up happening is we always ask the question, most places do, have you ever experienced physical, sexual, emotional abuse? And where that's placed, it's either placed right at the beginning of when you meet somebody or at the very end, right before you are going to end the session. it's the worst place. One, you're asking someone around their trauma history when you've just met them, and I think it's important to understand, that they may have had traumatic events. I think it's about timing in the relationship where they feel safe. One of the psychiatrists I work with, actually, he does it in one of the best ways I've ever seen. And when he asks a question, even if it is on an assessment, he will let them know, I'm going to ask some tough questions. It may relate to some of your experiences as a child around someone who might have hurt you. I need to ask just to have a better understanding, but you can always refuse to answer. So he gives them permission to say, I'm not ready to talk about that, I can pass. And then when he's ready to ask the question, he does it about in the middle of the session, he will always ask permission to ask the question again and gives them a right to refuse to answer. And like I said, I think if we go in with the trauma-informed lens, I think we just go in, probably they've had exposures to trauma, probably, until you could weed it out later on. And I think if you just go in with that lens right away, understanding that if you have people who are using that you're working with, they probably have been exposed to a lot of traumatic events. And then you just weed it out as time goes on. But I think it's really important that you get consent. And you also have them know why you're asking. Because sometimes it's really hard for people to say no, and they think they have to tell you. So it's important, like I said, get consent, but also telling them why it's important for you to know. And that, I think, is the best kind of policy or stance to go by. But I will get into some of the tools and strategies a little bit later for sure. So some of the trauma reenactment symptoms. And so I'm going to break it down into 4 different areas and then tease in how substance use can mimic or actually counteract some of the trauma symptoms. And a lady in the States named Janine Fisher, she's a Dr. Janine Fisher, as well as Trauma Matters, which is also, it's a great document, and some of the trauma toolkits that are out there, does it in such a beautiful way to really explain how substances and some of the symptoms can counteract and why people might mimic or actually counteract some of those symptoms. So some of the reenactment symptoms are attraction to dangerous situations, sexually acting out, suicidality, the self-harm, attraction to abusive relationships, and many types of self-sabotage. So drugs such as alcohol and cocaine can facilitate or mimic these symptoms. Usually, again, I try and make it as interactive and ask the question, why do you think alcohol and cocaine can mimic some of those situations? And so if we're looking at high risk, and I'll just go back really quick, if we're looking at some of the attraction to dangerous situations or the risk-taking or those kind of things, when you work with someone who uses cocaine, they'll talk about how they feel 10 feet tall and bulletproof. They feel superhuman, they feel fantastic. And when you add in some of the alcohol as well, what ends up happening is your inhibitions are reduced and you take much more risks. And so using some of the substances can really reenact some of that behavior. It also helps decrease the likelihood of trauma memories breaking through by ensuring that they are an endorphin or adrenaline high. Sexually addictive behavior not only produces a high, but also involves reenactment of the sexuality or the unsafe behavior as well. So persistent expectation of danger. So this is when someone doesn't really ever feel safe. This is where they might be always locking the doors and the windows and always feeling like they have to watch their back. They have increased anxiety. They're easily startled. They're not sleeping well. I actually have a few ladies who don't sleep at night at all. Terrified to sleep at night, and one lady will only go to sleep as soon as her family members are awake, so she knows that they're alive. So that's the only time she will sleep, is if they're awake. And I have another one that absolutely cannot sleep at night at all, and all she does is pace all night long because she cannot sleep at night. So alcohol and marijuana are particularly useful in reducing the hypervigilance. So it helps decrease. And when I talk about marijuana, this is for the people that don't experience some more of the psychotic effects, because marijuana has the upper and downer pieces to them. And for some people, they might have more of the psychosis or the anxiety and the paranoia. So this is for the ones, for people who don't experience that when they use marijuana. For the ones that don't experience that, it actually can help reduce some of that hypervigilance feeling. Cocaine and speed are useful for increasing the hypervigilance. And again, I always ask the question, why do you think someone would want to increase hypervigilance? And why would someone want to always feel like something's around the corner? And for someone that has trauma, why they would want to reenact that is because then they feel like they're in control. Their guard's not down. They can, with cocaine and speed, you can stay up for days and days and days. You don't have to sleep at all, and you can always watch your back. And then again, you always feel this bigger sense of self, and so they feel safer. And so that's why someone might want to mimic that. I touched on that one already. So hyperarousal symptoms, this is the intrusion. This is the one that's the most destabilizing and has the highest chance for people relapsing when this isn't, when people are being flooded by this. And so this is where they have the nightmares, the flashbacks, their emotional regulation is quite out of whack for them. And so if someone is continuously feeling that they're going to be intruded upon by the memories, by the nightmares, they will use substances to actually counteract that. Because again, like I said, it is so destabilizing for them, and it is so difficult for them to cope with this. And so one of the things actually that works the best to counteract the hyperarousal symptoms is actually opiates. And you'll see a lot of people in Edmonton here, it's more around prescription drug use. We don't see as much heroin here, although it is here. There's just not as much opportunity for heroin here. So you'll see a lot of the prescription drug use. But opiates actually, out of all the substances, works the best, and that's why you might see a lot of the people we work with using a lot of the opiates. They might use alcohol or marijuana to induce the relaxation or numbing effects and having that chemical barrier. Restricting food and overeating can also produce the same effects. For someone that might be drinking, what someone might do is they might use cocaine to help sober them up so they don't get so intoxicated, so that they can still have the chemical barrier, but they're also not in a place where they're unsafe. And so they might use, and that's why you might see a lot of people using different substances. And so cocaine in conjunction with alcohol might be able to mimic and also have the chemical barrier at the same time. And so lastly, the numbing or the hypoarousal. So this is where people shut down, they isolate, they disassociate, they feel numb. This is when they come in and they may tell you about some of their history, and it's like they're telling you about the weather. And I mean, they might be talking about deep, dark places, and it's like they're just talking about the weather, completely shut off. And so my question in regards to this, why would someone want to counteract the feelings of being numb? Because a lot of times they're trying to shut off. A lot of times they use to shut off and have that chemical barrier to numb out, right? So why would someone want to counteract that feeling of being numb all the time? And so usually what ends up happening is if someone is feeling so disconnected with life, it is just as difficult to always feel so disconnected and depressed and numb all the time as much as being intruded upon. And so in a paradoxical way, sometimes they might use to counteract suicidation so that they actually feel alive. And they might, and you'll hear people talk about when they do self-harm, right? Sometimes it's their only way of feeling alive and feeling. And same thing with substances, that sometimes it's a paradoxical way of counteract suicidation. I just want to make sure I'm on time because I know we started a little bit late. Okay, we're still good. Trauma and mental health. we've talked a lot about trauma. I've touched on PTSD. And after talking about substance use, when we work with people who have substance use and trauma histories, what we end up finding out, what we end up seeing actually, is when they come into services, they'll come in and they'll tell you about a lot of different diagnoses that they have. And actually, the percentage of them having a diagnosis of PTSD is very low. And on here it shows 16.3% come in with that diagnosis. And so just understanding that just because they don't have the diagnosis doesn't mean it's not presenting itself in a variety of different ways. And so what we will see is major depression, bipolar disorder, a lot of the anxiety disorders, and so it's, and you know, a few others. And I'll touch on one of them in particular a little bit later when we talk about, I'll touch on that in a little bit later, one of the diagnoses that we actually see the most, but I'll get to that in a second. So I just wanted to make sure that we're aware of, just because they don't have a diagnosis of PTSD, it actually can branch into a lot of different areas. And so it might become bipolar, might be depression, it might be general anxiety disorder, those kind of things. And so just being aware that they may come in with a lot of different diagnoses, but it doesn't mean that they don't have a pretty significant history of trauma. It's just presenting itself differently, that's all. So, trauma-informed practice, what is it? And so, when we try and change that lens, instead of asking yourself, how do I understand this problem or this symptom? Because I think a lot of times what we end up doing is pathologizing quite a bit in our field. It's better to ask, how do I understand her? So how do I understand the person that's sitting in front of me instead of the problem or the symptom? And a lot of the treatment, we focus so much on the problems versus understanding its adaptations based on their experiences, and it's a way of coping. And so it's just changing maybe our language and changing our lens just a little bit. So here's 10 principles of trauma-informed practice. And in regards to this, I'll go through them individually for sure, but when I put together, actually I do this in a full day, and I know I'm talking really fast, and I'm trying to jam as much information as I possibly can into the 2 hours that we have together. But when I've done a lot of research on different places that have trauma-informed practice and different principles that are available out there, I found this one, the 10 that I have here, pretty holistic, and I quite like the way they've put it together. And this one's through Clinic and the Trauma-Informed Toolkit in Manitoba. And I found that the 10 statements here, like I said, is very holistic in their approach and kind of touches on all the areas to create a site and a practice to support people that have trauma histories. So the first one is recognize the impact of violence and victimization on development and coping strategies. Again, about making sure we understand that it's adaptations based on their experiences and it's a way of coping, versus sometimes what we end up doing is focusing on the behaviors and then labeling them a certain way, where we might call clients resistant, non-compliant, manipulating. Like, we'll use pretty negative terms to describe certain behaviors, but if you reframe what's going on and understanding how they got to where they're at, you'll understand it's actually development and coping strategies, again, based on the traumas that they've experienced. Identify recovery from trauma as the primary goal. I think for the work that I do, I think it's really, really important. No matter the work that we do, it needs to be holistic. We can't put things into compartments. If we just focus on the substance use and we don't look at anything else, we're missing the boat. If we just focus on, say they have a diagnosis of depression, and we just focus on the depression, but we don't look at the substance use and we don't look at the history of trauma, again, we're still missing the boat. So I think it's really important that we're very holistic in the approach that we take, but understanding at the core of what's going on for them, it probably is a history of trauma. Employ an empowerment model, and I'll tie this into the strive to maximize choices and control over their recovery. And the reason why I tie those two in together, because I think it's really important in the practice that we do, is being very supportive and employing that empowerment model, but also helping people feel like they have a right and they have control over the treatment plans that they have, and they are the captain of their ship, and we're just here to support them through this journey. And that, because what ends up happening is, particularly, for example, particularly the women that we see across their lifetime, they've had a lot of different exposures to trauma, and a lot of times it's happened since early childhood. And it's always been in position of power, people in power. And so when we come in, there's always going to be that imbalance. And so even if we come up with a suggestion, sometimes they feel like they can't ever say no to us. And so it's really important that we make it explicit when we work with them, that they have control and they have a right to choose what's going to work best for them, because they really are the expert in their life and they really do know themselves best. We're here to help guide them and support them, but they really know what's going to work for them. And so I think it's important that we combine the two together. And again, based in relational collaboration. I think it's important because a lot of the women we work with have so many service providers involved. Majority of the time, they may have an outreach worker, a family support worker, maybe they have children's services involvement, maybe they have an addiction counselor, maybe they have a PCAP worker. You know, they have so many different service providers involved, and I think it's really important for us that we all work together. We all work on one plan versus having 5 different plans, because what ends up happening is if we have 5 different plans, there's no way she's going to be able to fulfill all 5 plans. And so how can we work together to make it much more, again, holistic and supportive? And she actually has a voice at that table in regards to the support workers that are involved with her. The work that I do, I'll touch on that again really quick. The work that I do, we really encourage a lot of service team meetings and case conferencing and a lot of case management. And it works so much better, even in the work that I do one-to-one, because I get an understanding of what the other goals are and what the other things that people are working on with them. And I get a better understanding of the big picture of what's going on for her versus her coming in for an hour and then leaving, and then I don't see her for another week. So it's really, for me, actually, it helps tremendously in the work that I do, that I actually get to see everything that's going on for her and the different services that are involved as well. Create an atmosphere that is respectful of survivors' need for safety, respect, and acceptance. And this is from the moment they walk into the building all the way up to reception to when they come and see you. I think it's really important to kind of do an evaluation of what that experience is like for them. I know actually some of our staff a couple weeks ago they went off site, and then one by one, each of them had to come into our service and access services as if they were a client to experience what that's like for them. And it was tremendously impactful because they understood what worked and what didn't. And that goes to like even the signage that we have in the building. So we know that we're being very client-centered and respectful. Sometimes we'll do assessments, like I've seen sites where they've done assessments and there's like 8 other people sitting within 10 feet of that person, and we're asking very personal information, and that's not respectful to them, and that's not a safe place to be doing those assessments. And so it's really, really, really digging deep and thinking about, okay, what is the service that I provide and how do I make it safe for them? And like I mentioned a little bit earlier, and that, like, there's even dentists in our city that are trauma-informed, and they are very supportive, and they make it explicit when a person comes in and how they can support them if they have trauma histories. Emphasize strengths and highlighting adaptations over symptoms and resilience over pathology. I've touched on that one quite a bit already. Minimize the possibilities of retraumatization. And I think this one's really, really important. When I talked about a little bit earlier on about reenactment and clients reenacting the traumas, and I remember giving an example, and I think it might have been in the first session, the importance of that, and sometimes with the best of intentions, us as service providers can slip into reenacting their traumas without even realizing we're doing it. And so the example I gave before was Say you had a lady, and again, I'll use the substance use part. Say she was wanting to go into detox, and she goes to, and you're her worker, and she comes to you and she says, the only way I can get to detox is if you could provide me some cigarettes. Please, please, please provide me cigarettes. I can't make it. I can't do it. And you say to her, I'm not able to do that. I'm sorry. And then she's like, but it's the only way I can get there. Can you do it for me? And then you go and actually buy her cigarettes. So she goes to detox. And then you tell her, I'm not supposed to do this, so don't tell anybody. When we look at trauma reenactment, what are we creating by that scenario? Just by saying, hey, you know what? I'm doing it for you, but don't tell anybody. And if you go back to, again, a lot of the clients that we see have a history of child molestation. So let's go back to that. A lot of times what happens is they're groomed for quite a long time before the actual sexual assault happens. And they're groomed by gifts. So you're providing a gift that's a special gift that they don't give to just anybody. And you're also creating secrets. And now you have a special relationship, and you created secrets with that person. And no matter what, that relationship is altered, and it can never go back because we've just already slipped into reenacting some of their traumas. And this scenario, I've seen this scenario happen numerous times, and where I have clients come in, and like I said, the relationship has completely changed, and now she's terrified to disappoint you. She's my friend, or he's my friend now. I have their cell number. That boundary is so important to keep in place. And like I said, with the best of intentions, sometimes we're trying to support them the best way we can without realizing the harm that we might be doing. And so I think it's really important to be, have that in the forefront of how we could make sure that we're not re-traumatizing them. The case scenario that I talked about a little bit earlier in regards to the lady that came in to get services and support, in that example where she came in and the person kept focusing on the assessment and was asking questions, and she was getting more agitated and more agitated. And a lot of times what ends up happening is because she mentioned she wanted to be safe, that's why she wanted to go to detox. And what do we do right away? We go into safety questions, and it actually escalated her. And so what ended up happening is the worker said, if this is how she's going to be, she's not appropriate for treatment. And, and so again, we've created a situation, and it was on our end, but we've actually blamed the client for what we were doing wrong. And that client actually was exceptionally appropriate for treatment. It was completely false. And so it's really important for us to be very cognizant of how we might be able to do that. Actually, when I do the training, I actually have an activity we give to service providers, and we get them to break down into 4 different categories how our sites or people or services that we've seen, how we can re-traumatize clients and reenact some of this for them. And so how do we make someone feel unheard and unseen? How do we isolate clients? How do we make them feel powerless and vulnerable? And so we break them down into those categories, and we get them to go into groups, and we ask them, at their site or what they've seen, how has a client been unseen and unheard? How have they felt powerless or vulnerable? And to kind of really reflect on how we, in our sites in very subtle ways, can re-traumatize people. So I think it's important to do some of that reflection. Strive to be culturally competent and to understand each person in the context of their life experiences and cultural background. Sometimes I think it's really important to recognize that the healing that they do could be in context with their cultural background. So I think that piece is very, very important. And to solicit input and involve the clients that we work with in evaluating services. And this one is key. Sometimes we come with these grand ideas and, these programs, and it's like, oh, this is going to be the best program out there, and it's not a fit. And so it's really important that we get feedback from clients to make the program work for them versus, the top down. And so, for example, I run a trauma-informed addiction recovery parenting. It's a 14-week program. And every week I get feedback from the clients that are participating in that group so that they have input in how the program looks, but also I'm making sure that the information I'm providing is meeting the needs of the clients that are accessing it. And I think it's so important that no matter what we're doing, we're always getting feedback from them so that we're matching services. And so instead of finding ways to exclude people in services, we're finding ways to keep them engaged, and it's going to fit for them. So as service providers, so this part now, I'm going to swing quickly into some skills and strategies. And as service providers, what strategies can we use? The first one I'll touch on is safety. And not just safety for safety planning if someone's involved in a violent relationship. For sure, that's a piece of it, but also making sure we're looking at the continuum of safety and what that means for clients from, like I said, if you meet with them one-to-one, when they come into your office, asking them, do you want the door open or closed? So that they have a choice. When they go into group settings, that you talk to them about what that room looks like. Bring them to the room. If they have a lot of anxiety and a lot of fear, that strategize around how we can get them into the room, and they can choose the seat that they want. Sometimes it needs to be right by the door, and sometimes it needs to be at the back of the room so they can see the whole room. So really being cognizant of what safety really means for them, and it means a lot of different things, and also asking them what it means for them. Safety in regards to our own personal language. I always say the way we talk and the words we use is insight into the soul and the philosophy and the values that we have. And language is exceptionally powerful. And so, you know, if we're always describing clients based on behaviors, like I said, inappropriate, resistant, non-compliant, you know, if we're always using those that type of language to describe clients versus saying, you know, I met with, and actually using her name. You know, I've had clients that will go into services numerous times, and she comes and she walks in and she describes every diagnosis she has before she even introduces her name. That's who she is, and she has to make sure people know that, because that's all they care about, versus who she is as a human being and what her name is. And that's, you know, and that's not uncommon, and I think it's really important to be very cognizant of her language. I touched on the environments, but also even within your office, I have fidget toys, I have distractions. For some of the clients, particularly if they've done some therapy as a child, they've been taught art therapy. And so sometimes I'll have paper and pens and crayons, and even when we're doing one-to-one sessions, that they can still doodle, because it helps them to focus. Some of our intensive programs, I've talked to the counselors up there, because sometimes if someone doesn't understand that maybe they need to doodle to actually focus on what's going on and being present in the room, they've been actually discharged from programming because they're not paying attention, or they're not being respectful, or for a variety of reasons because they didn't understand the purpose of what they were doing. And so sometimes what I'll do is I'll talk to the counselors or whatever program they're going into just to let them know, and then telling the client to also let the group members know that you do this to focus, and it's not to be disrespectful, it's just helping you focus in the group. So the Therapeutic Alliance, I touched on this quite a bit. Scott Miller has a stat of 80% of outcomes, successful outcomes in treatment, is based on a therapeutic alliance that you have with the client. And so it doesn't matter your intervention, whether it's narrative therapy, MI, solution focused, it doesn't matter the intervention that you come in with. The biggest indicator of success is therapeutic alliance and the importance of that. And so it's really important to recognize that piece, and sometimes it takes a long time for that to build. And like I said, sometimes we may perceive that they're very engaged in services because they might be disclosing a lot, but there might not be an actual connection there at all. And so this one is the most important, and that will be the biggest indicator whether success happens in that relationship. The next one is to alleviate their anxiety and stress. And this one, and I've touched on a lot of different ways we can definitely do that. Another way that I do that, for example, if I'm referring someone to a residential treatment center, a lot of times they have open groups, and I'll get clients and they can go with a support worker with them to an open group, so they can go on site to see the facility, to meet some of the staff, to get an idea of what that center is like before they even go. So there's lots of different things you can do to help them alleviate some of their stress and anxiety when you're looking at treatment plans for them. But this one's a really, really big one, because when I do the full day training, and unfortunately I wasn't able to do it just because of the logistics of it, I play a couple of 30-second clips. And the first clip is a very relaxing music. You know, you hear birds, and you hear the beach and the ocean, and it's very relaxing. And I get the group members to ask, you know, to kind of talk about what they felt. And a lot of times they felt really relaxed and calm and cool, and, you know, and then I get them to listen to another clip. And it's of the Jaws theme, and ask them to kind of talk about what they felt with. Like, and they said, you know, my heart started to beat, anxiety. You know, that music is an indicator that something's going to pounce on us soon. And I use those two clips to really maybe help us feel that more emotional connection to what it could be like for someone that has trauma history. Because for us, for people that haven't experienced trauma, usually going through day to day, we hear the beach music. We just go about our business, and it's just the way it is. And sometimes we're thinking about all the things we need to do for the rest of the day. We're making a shopping list. We're just going about our business, and we're pretty relaxed. For someone that has trauma, of every second of every day, they hear shark music. And so if their being is always hearing that shark music, this piece of alleviating some of their anxiety and stress is key in working with them. And so just understanding that, again, that's why they might miss appointments, because getting to us sometimes is the hardest thing they've had to do, is actually getting to us and walking through what they need to walk through, because, again, they always hear shark music. And it's just another way just to kind of have that emotional connection to understanding what it could be like for someone that has a history of trauma. Education. And this is from if you do one-to-one, if you do psychoeducational groups, or even process groups or more intensive work with them, it's really, really important to make those links for them and having them understand how trauma presents, and making the link even around their substance use and why they might be using. Because sometimes it's like that light bulb moment, and for a lot of the women we work with, they really need to understand why. And sometimes they haven't made that link yet. And this one's really key for them to help understand why they might be using and why they continue to use, and the difficulty it is. Because again, there's also a lot of guilt when they're trying to go into recovery and then they relapse. And that guilt is so huge for them. And so helping them understand this process for them is really, really important. When I talked about the 4 key impacts, I talked about affect regulation. And I really do believe at the core of what we want to do is we really want to, again, help them have that internal ability to self-soothe. And as you see, I put grounding and self-soothing up here as my title. And you notice I didn't put relaxation. I think sometimes what the terms that we've used in regards to some of those grounding activities, we've called them relaxation. And again, when we want to minimize retraumatization, if you have a group coming in and you're actually going to do some relaxation techniques, and you say the word relaxation, and then you ask them to close their eyes, because usually that's what ends up happening, and then you tell them, okay, take a deep breath in, take a deep breath out, I'm going to get you to relax. What happens for someone, again, who's being molested as a child? That's exactly what they're being told. Just relax. And so, again, language is so important in being cognizant of that. And so we use the language around grounding and self-soothing, and the importance of this to help emotionally regulate, and finding the internal ways to do that. When I go through a lot of different techniques, I make sure I go through a variety of different ones, because some of them might not work. They might want some better than others. And I also want to make sure if you have people that have a history of psychosis, it's really important that you do guided imagery with them and that they do more of the tactile grounding in the moment type of grounding activities, more of the sensory work. And so it's important that you understand which ones you're giving to the clients that you have as well. I get them to work on it numerous times for quite a while before and I ask them not to use it when they're stressed. I get them to use it daily when they're actually calm and they get used to using it. So when they are really feeling confident with it, then to use it when something happens and they're not regulating really well, because then it becomes automatic. If you get them you say, hey, try this and try it when you're stressed, and they've never used it before, they'll come back and say, oh, this does not work, this is terrible. And it's really important that it becomes a part of their being, and it takes a little while to do that. So I get them to do it for a while before they're actually stressed, and then we go into different ways of self-soothing and having a variety of ways of doing that. In the addiction world, this is the term, containment is a term that a lot of therapists have used for many, many years. The downside of using containment is we don't use it in conjunction with emotional regulation. So what ends up happening a lot of times, and it's an old school philosophy as well, and so when I talked about myths and facts in regards to you have to be a specialist to work with someone who has trauma symptoms, in the addiction world in particular, the analogy they've used is people need to be clean and sober for 2 years before they can work on their trauma. And that, again, is an old school philosophy, but I think some people still use that today. And so what they'll do to help them stay clean and sober for 2 years is they'll talk about containment. And they'll even use guided imagery. And they'll get them to envision a box, get them to even decorate the box, to put all their traumas into this box, lock it up, put it on a shelf, and leave it there for 2 years. Not good. Because you're telling someone it's not okay to talk about it. You shouldn't be feeling what you're feeling. And again, when we go back to substance use and their trauma, and a lot of times they're using to cope with the traumas, and we're asking them to get clean and sober, but we have not put in place an ability or skills or any coping in place of it, we actually can do a lot more harm. And again, some people cannot get clean and sober because they cannot cope with the flashbacks and the nightmares and the flooding that they get. And so, like I said, it's so important to be very holistic in our practice. And when we use containment, we have to use it hand in hand with emotional regulation, so some of the grounding and the self-soothing techniques. And what we talk to people about is using containment when in the right social circumstance, and when it's okay, and finding a safe place to be able to emotionally regulate. For example, if they are in a doctor's office and the room is full of a lot of different people, maybe talking to the person that's sitting beside you might not be the best option, or talking on the phone where everybody can hear what's going on might not be the best situation. So in that moment, they might need to contain, but as soon as they're done, then they need to find a safe place to be able to regulate their emotions and finding a safe place to be able to work through what they need to work through. Because we want to teach them how to balance. And sometimes we have those ebbs and flows. And so in conjunction with affect regulation, containment has to go hand in hand. We can't actually just focus on containment and tell people to not talk about it. Or I've heard people say, you know what? Again, using the box analogy, put it all there, and then when I see you in a month, then you can come and talk to me about it. But they have to sit with that for a month. That's not a safe thing to do for them either. And so I usually use a 24-hour clock, and I get them to put in who is available for them on that 24-hour clock, and then having emergency numbers in place just in case, and so that they have different outlets and different people that they can connect with, because it's important that we don't work in isolation, and it's important that they have a variety of people to support them. Just going to check the time. Okay. So triggers. The next piece that I do with the women I work with, and this is where around more of the skills and strategies, and this piece is really important. I think we do this a lot in substance use related to their substances, but we don't always do it in relation to emotions. And so it's important that we actually relate it to their emotions. And so I ask them, what makes you feel scared or upset or angry, and what could cause you to go into crisis? But again, we want to help them be able to emotionally regulate and be aware of it, because a lot of times they'll talk about it's the volcano and it's like something simmering, but they're not aware that they're simmering, and all of a sudden they blow. And so we want them to help be able to catch that, because again, they disconnect from their body and their emotions so much. And so some of the answers they come up with are not being listened to, feeling lack of privacy, being alone. That one I'll touch on really, really quick, because in Edmonton we have a Housing First project. And I think this piece is a really big one for understanding why sometimes people bring people into their homes when they get their housing for themselves on their own. And for people that, one, a lot of the women, may not have ever lived on their own, so they might have had children's services involvement when they were children as well. So they grew up in foster care, group care, may have lived with partners, friends, and sometimes when they finally get an apartment on their own, this piece is huge, and it's absolutely difficult for them to be on their own, and so this one's a huge trigger for them. So yeah, I get them to answer some of those questions. We do this particularly again around substance use, but I also get them to use this around their emotions, particular time of day or night that's difficult for them. If there's a time of year, again, sometimes there's those anniversary, and sometimes it's the fall, sometimes it's the spring. Just being aware of what time of year is very challenging for them. If it's about contact with specific family members, and that could cause them to go into crisis. And then other. And then second, identify your early warning signs. A signal of distress is a physical precursor, and it's the actual emotional response before they actually go into crisis. Again, sometimes clients aren't always aware of this, so it's important for them to kind of really do some reflection of what could their body or their emotions be like. So some will say they feel restless, they have agitation, pacing, shortness of breath. I have a lot of clients who say, I didn't realize that I hold my breath when I get upset. And really doing some of that self-reflection, they can actually be much more aware of breathing and the importance of breathing. Tightness in chest, sweating. What might you or others notice before you lose control? Sometimes when I ask that question, people are like, I have absolutely no idea. I go from 0 to 100 and I black out. I have no idea what it looks like for when I'm getting when I'm starting to lose control. So what I do is I get them to ask the people around them that's closest to them. So what does your partner notice? What does your mom notice? What does your best friend notice? What do they notice? Ask them when you're starting to get upset. So some will say they notice that I start to eat more, that they're breathing heavier, they start to clench their fists, they start talking louder, swearing, clenching their teeth. Sometimes they start laughing, giggling, maybe they start to cry. And so it's really helping them to be much more in tune to themselves so that they can actually be able to catch it before they go into crisis and lose control. And then lastly, I get them to ask, I ask them, what is it that helps you calm down? And I think this one's really important in regards to the first bullet. Sometimes people are like, when I'm really upset, I need space and I don't want people coming after me. For example, if you have, say you have a day program and you had someone get really upset during one of your workshops and they leave the room, and what ends up happening is you'll have 10 people follow that person to ask, and with the best of intentions, are you okay? Are you okay? Are you okay? And for some people that actually escalates them and makes it worse. So being aware that I really need to be alone and being able to communicate that is really important. Sometimes people actually need someone to talk to be able to process it right away. Sometimes they need to take a hot shower, some of the deep breathing, exercising, writing in a journal. And I get them to really look at a lot of different things that help them kind of self-soothe and kind of settle things down for them. Some other strategies, sometimes people need to do that cocooning, so they'll lay down and they'll wrap themselves really tight in a blanket, and they'll just lay there and cuddle that blanket for a bit. And so sometimes that really helps. Sometimes using cold water and putting it on their face, or using ice cubes and putting it on their arms or that kind of thing, just to kind of bring them back into the moment. It's also like a harm reduction technique for people that self-harm. Instead of actually cutting, they might use ice cubes instead, those kind of things. The last thing I'll touch on, and when I do this full day presentation, we actually do go into a lot more depth about this section, but I think it's important that we at least spend a couple minutes talking about it, because when we work with people who have trauma histories, it's really important to do some self-reflection on that and being aware of vicarious trauma. Because, you know, we always have to make sure we're taking care of ourselves as well, because, again, sometimes the work we do is hard. Some of the stories we hear are really hard, and no matter what, we absorb those stories. And so it's important that, you know, when I talked a little bit earlier, actually at first with one of the questions in regard to clinical supervision or having that support system within the place that you work, that you, not only with the self-reflection and making sure we're aware of our belief systems, but also on the flip side, that we have a support system in regards to being cognizant of the vicarious trauma. And so one of the questions to ask yourself is, how do you feel when someone discloses trauma? You know, sometimes people say, you know, I feel sad. Sometimes they say I don't feel anything. And that's also a concern when you're not feeling anything anymore. But also just kind of doing that reflection, like really sitting down with it and like, how do I actually feel about that? And, you know, for the work I do, because again, 100% of the women I see have very significant trauma histories. Sometimes it's really important that you be strategic in planning your day. And so if I know I'm going to see someone that might be more difficult for me, I'll make sure I plan it at a certain time of the day, and then I also book a time with a staff member to debrief after. So, you know, just finding times in the day where you're able to do that. I think sometimes we get so caught up in our day-to-day stuff, and we go from one appointment to the next, to the next, to the next, and we didn't even get a chance to process the first one, and if we've already heard, you know, 5 or 6 different stories of pretty significant trauma. So it's really important that we build into our schedule. Yeah, I think that's really important. Just recognizing, again, the stories we hear do affect us. In our work, we bear witness to daily pain, despair, victimization, as well as the rewards of the work that we do. So, I mean, absolutely, we see both sides of it, but just being aware that it impacts us. And sometimes people will ask, oh, but what are you doing for self-care? You know, did you have a bath today? Did you do this and do that? And I think sometimes the flip side of asking those questions, it actually implies we're not doing something right or we're doing something wrong. And it gives that counselor or that worker facade that we should be this bubble that aren't impacted. And, you know, we can have all the best self-care in place. It doesn't mean it doesn't hurt sometimes, that the work that we do. And so, you know, just having a safe place to be able to work through some of that and talk about that. And also, how do we be strategic within the work that we do so that we always put in places that we can get that support. Give yourself permission to experience the emotion of your work, but also value your efforts as well as your successes, and to always laugh. So that is it for my 3 sessions. We are done. It's just if anyone has any questions, because I think we have a few more minutes. So if we have any questions in the virtual world.
I don't have any new questions, but I will just go back to Gary a little bit. Gary gave us some more information about what he was actually asking. So his original question was, when children have experienced trauma in early life, how do we help but in the same time not take them back to the traumatic event? And Gary did indeed mean a child growing up. And so if the situation is having the traumatic events brought back into their lives because of contact with family who have been out of contact for many years, how would you deal with that?
Oh, that's a complicated one. And, you know, oh, yeah. The reason why I'm kind of like, about it, just because I always see every person as an individual. And some of the strategies I use is different for different people. So, for example, I had one lady who was doing quite well, and all of a sudden something happened within the family, and she had to have contact with a family member that molested her growing up. And that just sent her spinning. And part of it is we really had to discuss around boundaries and talk about her right to say no to family members and being able to acknowledge that. And so for her, we had to go on a different path. For another person that I was just working with yesterday, some of their healing had to do with contact with family. And some of the amends that were being made. And so I know I'm not being really clear, and I'm not being as helpful as I possibly can in that answer. It's just because it really does depend on the person. And the one key thing that I'll definitely say, no matter what, when you're working with someone with trauma history, the worst thing you can do is to get and I do tell clients this. I told one of them I was working with yesterday that, you know, you don't have to go into very specific detail to understand the context. And actually getting them to go into specific detail can be more harmful. And so I think making sure that you kind of set those parameters, that you can understand the experience and the context without having to go through every second of every moment of the experience.
I think those are really helpful comments, Kirsty. I just comment from the child's perspective. It's been a long time since I worked as a therapist with children, but I can comment a little bit, and this is also reflects the kind of work that we do at our organization with children who've been traumatized. So the situation you've described is where there's both a need to be in touch with the person, and then there's, of course, the double-edged sword. There's always that double-edged sword, and we see this all the time, particularly in protection situations. So the important thing is that the caregiver have a trauma-informed approach with the child. They understand, they're prepared for that, and they can help be a support to the child as well. Not forcing the child to talk about it, giving the child metaphorical ways of dealing with the experience that they've had. Metaphorical being play therapy. Sand trays are particularly effective. Having therapeutic storytelling, using drama therapy, allowing them to act out their experiences rather than talk about it. And that's also a function of the play, so they can use, their robots or their dolls or whatever it is they're using to act that stuff out. The important thing is that the caregiver understand the story that they're telling, and they be able to interpret that without necessarily digging for the detail. Right. And then, also really making sure that the parents and the whole environment have, the caregivers have the appropriate training. So those are the most important things, I think, that I can recall anyway.
Thank you, Jean.